Welcome to the 22nd IACAPAP launch and learn webinar on the role of parents in management of neuropsychiatric disorder in children, research gaps, and experiences in low and middle income countries. Today we have Dr. Mashudat Bello-Mojeed, who is going to take us through this webinar. Dr. Mashudat is the Chief Consultant Psychiatrist, Child and Adolescent at the Child and Adolescent Mental Health Services Center of the Federal Neuropsychiatry hereby in Lagos, Nigeria. She is a postdoctoral research fellow and a fellow of both the West African College of Physicians and the National Postgraduate College of Nigeria. And she has excellent academic degrees in child and adolescent mental health. She's a clinician. I am your chairperson today. My name is Mohammed J. Korova, acting head of department for pediatrics and neonatal nursing, Faculty of Nursing in Sierra Leone, and IACAPAP vice president. So we are going to have Dr. Mashudat as speaker today. Just as you can see her, Dr. Mashudat is actively involved in delivering quality patient care, scientific research and training for specialist and non-specialist caregivers, including young persons, teachers, and parents. She works closely with parents, family, and caregivers, and the affected children in the community, schools, and clinical settings. She strongly advocates for children and child mental health issues and their families. She continually collaborates with researchers within and outside of Nigeria and across cultural caregivers. So Dr. Mashudat is also committed to bringing important knowledge gaps in the field of child and adolescent mental health, evidence-based interventions, and improved well-being of individuals with mental health issues in low and middle income countries. We are happy to have Dr. Mashudat today. Now, let's have over to you, Dr. Mashudat. Now, during the presentation, participants who have questions have 5 minutes after the 30-minute presentations, or you can send your questions in the chat box after the presentation. And this is just an important announcement. Upcoming webinar, which is the 23rd IACAPAP Brain and Breakfast webinar, the 5 languages of psychiatry, will be actually held on the 21st of May, 2025 at 11 a.m. UTC Universal Time. So I'm going to be, the speaker for that would be Dr. Gorin Harper, who's a psychiatrist and associate professor of psychiatry at Harvard Medical School, who's also vice president of IACAPAP. And the other way of announcement, we also have the 27th World Congress of IACAPAP, which will be held on the 1st to the 4th of July 2026 in Hamburg in Germany, upcoming 2026. So be informed that this year the IACAPAP Congress is going to be held in Germany. Thank you so much. Now we are going to start the webinar proper with the presentation with Dr. Mashudat Bello-Mojeed. Dr. Mashudat, you can share your slides now.
Can you see my screen now?
Yes, you can see your screen now. Yes. That's fantastic. Considering.
Oh, thank you. So, a brilliant greetings to everyone. And we are all welcome to the 22nd IACAPAP Launch and Learn webinar. And a very important topic we're addressing today is the role of parents in the management of neuropsychiatric disorders in children, research gaps and experiences from a low and middle income country setting, using Nigeria as an example. So this is taking us through the learning objectives. At the end of this webinar, we should have gotten an overview of the topic, neuropsychiatric disorders, epidemiology, the burden of neuropsychiatric disorders, and examining neuropsychiatric disorders in low and middle income countries. We shall also examine current management for neuropsychiatric disorders in children in a child and adolescent mental health setting in Nigeria. We shall highlight some gaps in the related topic of today's webinar in terms of research areas. Very importantly, we'll discuss the role of parents in the management of these children with neuropsychiatric disorders, and we shall highlight the implications and the future directions of our findings on this topic. So as a background, neuropsychiatric disorders simply refers to a range of conditions encompassing neurodevelopmental disorders, emotional disorders, and behavioral and psychotic symptoms. The features of neuropsychiatric disorders include cognitive impairments, changes in behavior, emotional disturbances, anxiety and mood changes, compulsiveness, and sensory processing sensitivity or integration issues. Typically, neuropsychiatric disorders start in early childhood and persist into adulthood. There are impairments in different areas of functioning in neuropsychiatric disorders, such as found to affect broad and serious adverse areas of functioning, such as cognitive functions, biological, psychological, and social well-being. Invariably, affected children with neuropsychiatric disorders pose significant challenge on supportive system from health sectors, family, educational sectors, and related systems. Why address neuropsychiatric disorders in low and middle income countries? Globally, neuropsychiatric disorders, abbreviated in this slide as NPDs, are emerging challenge to healthcare systems, more so in low and middle income countries, with the peculiar findings of 1/3 of the world population that are children and adolescents who live in low and middle income countries. The population of these children in low and middle income countries have been related to some contributing factors for this huge population. One, there are reduced aspects of mortalities of children under the age of 5 years with improved healthcare services. Many of those children are living beyond the age of 5 years, implying more children will reach adolescence, where the prevalence of mental disorders increase and the onset of adult mental disorders will occur, implying many people will be affected with neuropsychiatric disorders. What this implies is that the higher rate of neuropsychiatric disorders in children in the low and middle income countries will result in so many children affected to have compromised developmental trajectories, disabilities with increased need for medical and habilitation services. That is, increasing population of these children in low and middle income countries imply increased burden in the system, especially with the existing limited mental health services in this region of the world. Similarly, it implies an overwhelming caregiving burden or parenting responsibilities on the parents of these affected children. In terms of the burden of neuropsychiatric disorders, the available research evidence on the epidemiology representing the global rates or the prevalence of neuropsychiatric disorders or mental and developmental disorders come from the global burden of disease, the current one of 2019 and the previous documentation of 2010. Globally, it is known that mental disorders were the 13th leading cause of disability adjusted life years in 1990 and constitute the 7th leading cause of DALI in 2019. The global burden of disease in 2019 showed a large proportion of the world disease burden to be attributable to mental and developmental disorders, with a mean prevalence of about 11.63 in children aged 5 to 24 years. So this is a summary of the global burden of disease 2010 and 2019, that the burden due to mental disorders was found to be present across all ages, with onset in early years before the age of 5 years, majorly found in neurodevelopmental disorders such as intellectual disability and autism spectrum disorders. These were found to continue at older ages in people with depressive or emotional disorders and schizophrenia. Males were found to be more represented in developmental disorders such as ADHD, conduct disorders, and autism, while females, in terms of gender, were more represented in terms of anxiety disorders, and the anxiety disorders and ADHD were found to be commoner in adolescents compared to children. This is just a diagram showing the aspects of what was demonstrated. We could see depressive disorders more in older age group. And then this next one, like we could see, many of the gender representativeness for male gender in blue in ADHD. You could see it also in autism, and those were the diagrammatic representation. So this just summarizes what I highlighted earlier on, that increase in population will increase the burden. And an important area of research gaps will be seen with the issue of data paucity, the paucity of data highlighted in the global burden of disease. Many data were found to be absent from many geographical regions, particularly in sub-Saharan Africa. And there are also cultural variations in the presentations and measurements that might have accounted for the non-representativeness of many of these neuropsychiatric disorders in the global burden of disease. Given that, it's very important we address this area of research gaps, particularly in low and middle-income countries, as related to management or context-related intervention issues. For example, compared to the global representativeness or larger or nationally represented epidemiological data, we could see the type of data we have, for example, in Nigeria. This was in a Nigeria primary care unit where the authors, Tunde Ayimode et al., look at psychiatric disorders in a primary healthcare center. This is another profile from Kenya, where Kamau et al. Looked at different profile in a clinical setting. And this one is from Ghana, where Kusi Mensah et al. Conducted a community-based survey to look at some of these neuropsychiatric disorders. So those are the types of representativeness that we have in terms of neuropsychiatric disorders in low and middle income countries. This takes us to the available management modalities in low and middle income countries. And I will exemplify this with, my center in Nigeria, the Child and Adolescent Mental Health Service Center of the Federal Neuropsychiatric Hospital, Yaba, Lagos. In this center, I'll be illustrating the multidisciplinary team approach for management of neuropsychiatric disorders. And this is a brief outline of what we have existing at the CAM Center. But it is important to note that in many low and middle income countries, we don't have this luxury of the wide varieties of the management modalities. Even in Lagos, in our urban center, it's only a few of the tertiary institutions that have this complementary of the management modalities involving the multidisciplinary team members, speech therapy, pharmacotherapy, occupational therapy, physiotherapy, educational therapy, psychological, social welfare, are part of the management modalities in this center. We could see at this center, it's important to observe some of the individuals or parents patronizing the center. They come in very early. We could see this woman exhausted, lying down, another woman moving from one point to the other, putting a child with neuropsychiatric disorders at the back. And this is the sitting area. And the nursing area is at this point, while the record is here. So usually they come in, they wait when the clinic starts, and after seeing the doctors in the consulting room, so this is a consultation space, another consultation space, and we have children and adolescents with neuropsychiatric disorders. So we are talking about the prescription being received at the space where the doctor attends to them. Speech therapy have their own unit within the same structure. Occupational therapy, we could see even as in the previous picture where we have a mother seated. A fast overview, we'll see that many of the individuals bringing children to the therapy room are mothers. Then this is physiotherapy. We could see a mother. We could see another child receiving a therapy in front of a mirror, and the therapist trying to work on the motor while the parents were observing from a rear. This is the educational therapy part of this, and the pharmacotherapy. The patients usually pay out of pocket at point of payment And we could see the back view as they are standing in front of the pharmacist part of the unit. And the social welfare services, very important, as they also had to be at the exits and at different points of management of children with neuropsychiatric disorders. Now, going to the main part of the topic, the role of parents. To make this very interesting and interactive, as practical as possible, a search of literature showed that there is paucity of data on role of parents in the management of neuropsychiatric disorders in low and middle income countries. In fact, the first review of literature we did not see any work addressing this across the whole wide range of neuropsychiatric disorders. So I and my colleagues at the Child and Adolescent Center put heads together and we set out for a focus group discussion. We had 25 parents of children and adolescents with one form of neuropsychiatric disorders or the other. And the aim of the focus group discussion was to examine the role of parents in the management of these children in African setting in Nigeria, and to also explore their experiences and challenges in their own perspective of view, and not just from the perspective of the professionals. And we have these research questions. We wanted to have a view of the parents on their roles in the management of their children with these disorders. We also examined what the experiences of the parents were, and we examined what factors in the view of the parents were found to be facilitating or hindering their involvement in the management of the children with neuropsychiatric disorders. And from the perspective of the parents, we saw this wide range of roles identified by the parents. First, in terms of the basic needs of life for the child, provision of feeding, finance, education, and all that, the basic need of life. The parents will have to do that. After that had been identified, the aspect of identification of features suggestive of neuropsychiatric disorders and reporting those findings, the parents were able to identify they're playing a good role in this. And significantly, they had to initiate the path to care as well as making decisions for those children. At the point of assessment, they provided information that were reliable to the clinicians during the assessment, as well as other parents in the clinical setting. In the various forms of management modalities highlighted earlier on, they were actively participatory in therapy, and they provide significant supportive environment at home for the child, and they also educated themselves. They had to read more, self-education, as well as educating other parents. The role also include the aspects of parenting practices and belief system. They took different key positions in terms of influencing the path or correcting some of the practices that were unhealthy in the management of these children. And importantly, they highlighted their significant role as advocates for their children. In fact, some of them said they turn into agents for their own children and had to defend them and also talk about them where they need to have a voice. These are some of the experiences we explored as part of our research question 2. Essentially, we have 3 groups for the focus group discussions on different days. And for the group 1, these were some of the experiences of the parents. I was not given adequate information when my child was born with this condition. Some of them even verbalized that they had no information. Some said, I've learned to be more compassionate since my caring for my child. Initially, it was like the world was coming to an end, but over time, they learned to be more compassionate. Some gave the aspect of having a lot of challenges in their marital life, and some were swindled multiple times by false healers in the hope of giving them cure for neuropsychiatric disorders. For the group 2, some of the parents in the group reported they had to do a number of spiritual treatments, all in the name of looking for a cure for the condition. And medication was sometimes unavailable. Some were tired of the treatment and kept on looking for a way out such that they won't have to be on medications, especially those with the psychotic disorders. And some had to do with side effects of the medications. Particularly in the group 3, we had experiences such as, I worry a lot about my child. I don't feel accepted in the community. I sometimes feel it's my fault why the child is this way. And some verbalize the aspects of the experience on healthcare workers who were sometimes mean to them. Okay, some didn't know what to do. I don't know what to do sometimes. So these were some of the challenges. Part of the challenges we identified for the our research question 3. Many of them had high level of stress, emotional burden, especially for the group 1, comprising neurodevelopmental disorders alone. There were a lot of emotional burdens, a lot of release of emotion during the focus group discussion, and parents supporting one another in the group. Some felt isolated, rejected, stigma, sibling dynamics. Initially, it was a lot difficult for the other siblings in the family to accept or find a space or find the experience of understanding that, oh, my other sibling needs more care, and that's why a lot of the attention had been given to the other child with neuropsychiatric disorders. But over time, parents, especially mothers, play a significant role in managing the sibling dynamics. Another challenge was the aspect of collaboration with professionals, and it was a major source of distress for them. And significantly, the out-of-pocket payment was very distressing. And many of them talked about the need for them to work while trying to get more resources to manage the child with neuropsychiatric disorders. So what are some of the implications or the future directions from our findings, as well as the aspects of the presentations in this webinar? Recent updates to the World Mental Health Organization goals emphasize that child and adolescent mental health disorders, the aspects of prevention and intervention have been emphasized across the globe, including the low and middle income countries. The provision of healthcare services for children alone in isolation have been found not to prevent mental and developmental disorders or have significant benefits for the affected children, unless when it is matched with important aspects of ecological approach that addresses problems in the systems around the child, such as the parents, the family, the schools, and related settings, in combination with targeted interventions put in place for the children. When these are put together in the ecological or family context, it has been suggested to have improved child-parent health outcome and improve well-being and quality of life for the child and the parents. As found in the focus group discussion, many of the challenges and the experiences found were psychosocial issues, especially among those with neurodevelopmental disorders. And this is in keeping with the findings of a study by Omigbodu et al. In 2004 on psychosocial issues in Nigerian children in a child and adolescent psychiatric setting, where it was reported that children with neurodevelopmental disorders, such as ADHD and conduct disorders, have or reported more psychosocial issues than those with psychotic disorders or disorders with onset in adolescence. So part of the future direction is such that it is important to start to look at the models that we have for current service delivery in low and middle income countries. And the trend now has to do with the aspect of task sharing, such that the aspect of the management will factor in the aspect of the caregivers. The other future direction has to do with integration of effective camp services into primary care setting. As mentioned at the beginning of the presentation, the findings in low and middle income country is such that there are virtually non-existing measures or child and adolescent mental health services put in place to address the early onset or neurodevelopmental disorders, or even those that are common in adolescents, such as depression and anxiety disorders. Parent and family-based intervention is another aspect of the implication, such that the key role of parents and family needs to be addressed in terms of what are the plans outlined in the interventions for children with neuropsychiatric disorders. It is also important as part of the future direction to address factors highlighted to hinder effective involvement of parents in the management of their children with neuropsychiatric disorders. We can never overemphasize the aspect of bridging important research gaps on these topics. For example, many sub-Saharan Africa and low and middle income countries don't have nationally represented data on neurodevelopmental disorders and other neuropsychiatric disorders. So, despite the fact that the aspect of the involvement of parents as non-specialists have been found to be effective from a number of publications and interventions, it is very important to look at the aspect of the overburdened or overstretched parents of these children that are experiencing significant and many challenges. And these are some of the papers that have addressed this in our environment. So in conclusions, the search of literatures and current focus group discussion observe that childhood neuropsychiatric disorders account for a significant health and societal burden in low and middle income countries. Parents of these children play key roles in the access as well as implementation of management plans for their children. Parents of affected children also experience various challenges ranging from stress, emotional burden, isolation, financial strains to stigma. Therefore, clinicians and other care providers should specifically and intentionally address the role-related challenges of these parents in the psychosocial care plan to improve the treatment outcomes for children with neuropsychiatric disorders. Specific interventions are needed to support the involvement of these parents in the management of these children for optimal outcome. In one of the saying of Jane Hall, at the end of the day, the most overwhelming key to a child's success is the positive involvement of the parents. And this can never be overemphasized from the topic of IACAPAP webinar for this month. So we've been able to cover this as our learning outcomes. Thank you, everyone. I hope it's been impactful. We can take our questions and go into discussion now. Thank you, everyone.
Yeah, okay. Thank you for the impactful webinar. So what are some of the practical ways we can prevent sibling rivalry in later life, especially when there has been a child in the family with special needs that skewed parental attention? That's a question from Dr. Motosho.
I will go. Thank you very much, Dr. Ayotunde Omotosho and Dr. Tolulope Ausa. Okay, so our IACAPAP president, Dr. Ayotunde Omotosho, thank you so much for that question. Asking for the practical ways we can prevent sibling rivalry. And I would like to go practical from some of the experiences shared by some mothers in our focus group discussion. There had to be active involvement of the parents in ensuring that there are, I'm trying to use the right word, there had to be outlined rules and regulations and things like that. Essentially, what's the example I'm giving, the mother initially had the younger sibling who was apparently more or maybe taller and healthier than the child with neuropsychiatric disorders, does not want to eat with the same plate, started to feel that the mother was giving a lot of attention to the other child. So the mother went about this by giving simple explanations on what the condition was or what condition the other sibling had to the other sibling that was a bit jealous and felt isolated. And after that, as much as possible, he tries to ensure that they eat together and had the child to support in childcare to also be empathic. So over time, it was a lot easier for her to ensure that the active participation of the other sibling made the child to be more empathic. And what was also done was that when there was a respite for somebody to take over the management, the parents also created extra time for the other sibling in the family, as well as ensuring that the child was carried along in the management of the child with neuropsychiatric disorders. So active involvement, psychoeducation, active participation, and breaking down the information in simple tasks will go a long way to ensure that we handle this or prevent sibling rivalry. I hope that is helpful. Hello, Dr. Kuruma. I can see another question. Okay.
Yes, there is another question here. This one says, could you please explain how you create your 3 research groups and what were your results for each groups? And
Okay.
the other one is, how do parenting style affects the management of children and adolescents with neuropsychiatric disorders?
Okay. Thank you very much for the questions. Well, because of time, we could not project many of the findings, but we hope as soon as possible, we'll have the result published in a child and adolescent journal. So the aspect of the question on the results, how were the results? I wanted to see the question. Now, what were the results for each group? Well, essentially, as much as possible, we covered as many neuropsychiatric disorders as possible. It was a focus group discussion. Group 1 had 9 mothers. Group 2 had 8 parents, 2 fathers, and 6 mothers. Group 3 had 1 father and 7 mothers. So we had a total of 25 parents. It was a focus group discussion, and we had 9, 8, 8 on different days. And we used thematic analysis to analyze the different themes that emanated from the results. So the important findings of the results were related majorly to the 3 research questions. We were able to examine the roles from the views of the parents as highlighted in the figure shown during the presentations, and the experiences for different groups. For example, the experiences in group 3 were a lot with emotions, a lot with spiritual pathways, unknown directions, and not knowing what to do. A lot with the group 3 that had psychotic symptoms in that group. A lot had to do with side effects of medications. At times, they found it difficult to know how to manage, and they also used a number of spiritual healers. So we use thematic analysis to do this. I hope that is helpful. Then the other one was to highlight the aspects of the parenting styles on children with neuropsychiatric disorders. Well, on the aspects of the parenting styles, it's not so different from the parenting style influence on other mental disorders. The healthy parenting styles have been found to be very effective or helpful in the management of the children with neuropsychiatric disorders, particularly those that has to do with parents being empathic, being available, being responsive, and being there to be able to analyze and respond to many of these emotions, as well as the specific needs of the children with neuropsychiatric disorders. Dr. Kuruma, are you there? There's also another question.
Yes, I am here.
Okay.
There is also a question from Adeola Fulayan, whether there were any differences in the family dynamics reported by caregivers depending on the position of the child with special needs.
Okay, thank you very much, Dr. Adeola Fulayo, for the comment and the question. The research that we conducted was majorly to make it practical for this webinar, and we did not specifically move on to address the position of the child with a special needs. The aim was to, or the plan was to progress to some other aspects of this, including quantitative aspects. There are many themes that were highlighted from the focus group discussion. But in spite of that, I will give an example of one of the parents from the focus group discussion that appeared to be related to the aspects of the position. There was one of the mothers that reported that one of the older siblings felt that the mother does not even have anything to do with every other person, that possibly it was because the child was the last born. But we could see that this is not related specifically because it's a focus group discussion. And we did not aim to compare with the other mothers in terms of the position of the siblings in the family. So some of the participants just mentioned that in the focus group, but not as if it was part of what we mentioned. Thank you.
Thank you so much. There is a last question here that says, what have been the challenges of involving parents or caregivers in supporting children and adolescents with mental health conditions?
Thank you very much for that questions. The challenges are huge and of different varieties. From the past, as much as possible, the challenges we are sharing are from the view of the parents, particularly. A significant aspect of the challenge highlighted by virtually all the members in the 3 groups of the focus group discussion were related to financial strains. Stigma was a big one, and being emotionally overwhelmed. In fact, for group 1, with mothers who have children below the age of 5 years and below the age of adolescent, many of them were emotionally overburdened. And the aspect of the financial constraint, they kept on bringing the theme of they want to work. They don't want to go on the streets begging for people to give them money for Pampers or for diaper. They don't want people to be giving them money to come for therapies. They would love to go out to work, but where do they put their children? And as they were discussing, you will see every member of the group continue to. And as part of the emotional burden, many of them also share the experience of having marital discord, husband of many of them telling them they are mad, or that they don't care if the child dies, that the mother was just wasting their time and energy. The mother should explain where the child comes from. We have significant number of them are single parents, and they had to look for means of survival. So these are practical challenges highlighted from the focus group discussion as viewed by the
Thank you so much,
parents.
Dr. Bello-Mojeed. We have exhausted our time. And before we end this webinar, I would like to actually recognize Secretary General Dr. Yetunde Oshodi, who is also attending part of this webinar. Thank you so much for synthesizing this topic full of practical facts with intellectual dexterity. We want to thank you so much for this, for honoring our invitation. Thank you.
I want to also thank all my co-researchers, my mentors, Professor Olayinka Omigbodun, Dr. Oluwayemi Ogun, my co-researchers on the focus group discussion, Dr. Ajayi Oluwatomiwa, Dr. Lawal Abisola, my colleagues, Dr. Ejarobe, Dr. Alalade, and my mentors in IACAPAP, Professor Petros Dubais, Dr. Kairi Munir, also and I want to thank everyone present on this webinar today. Thank you.